are joining, we can have a quick view on the panel experts today. There are a couple of more doctors who could not join today, and we'll be welcoming them along with all the experts here next series. And Dr. Lalita Darba, she is an expert in internal medicine based in Illinois. Dr. Rakesh Sharma, sir is also here. Is critical care medicine in NYC, New York City, and Dr. Shobha Chokalingam, cardiologist based in Illinois. Dr. Mata S. Arun, he has been for almost more than 3 decades in the hospital segment, also in epidemiology, and also working globally for many of the corporates to support on the policies. Dr. Khushbu Choksi, she has been helping not only in US but also in India of late now. Many of our patients, and today also we'll be listening to all the experts, including Dr. Khushbu, pulmonologist and critical care in Atlanta. Dr. Krishna Prasad, he's also online with us, neurologist, and also worked a long time in NIMHANS as well. And he is quite passionate to speak today on neurological exposure and impact from COVID. Dr. Samar Mehta, he is internal medicine, emergency medicine, and infectious diseases. The expert is here with us. And Dr. Chandrasekhar Salimat, he is also one of the well-known figure from Chikmagalur, who is, he is very good in the Indian conditions, helping us understanding what is current and what we are going to have. Of course, he's not an of course on a lighter note, not an astrologer as such, but for sure with the insights what we are going to gather here together, he is going to help all of us to understand with the rich experience of our US doctors and experts how he can help all our Indian participants today. How do we really move in the right direction so that we don't get COVID-3 wave at all, right? So that's the whole purpose of this session, to bring awareness amongst the citizen of India. And this is not restricted only to Karnataka. We have spread the word to many cities in India. And of course, a couple of them are also joining from US. Some of my family members who are in Virginia, they will be joining, or they might have joined by now. And likewise, a couple of friends as well. And also with us, Dr. Shubhashri, and she is from Karnataka as well, and she is based in Illinois, working hard to also make sure that we get right exposure and practical tips for COVID-19 today for all of us. So thank you once again, all of you on board here, and we'll be requesting. This was more like a quick introduction for all of you. We will be having the flow as we have told in the beginning. We'll be going with the first, that is onset. So maybe I'll request Abhijit, if you can go with the onset flow. We'll be requesting with Dr. Chandrasekhar. So over to you, sir.
Yeah. Good evening, everyone. As we just briefly trying to cover about the etiological aspects of COVID-19. Okay. So basically, COVID-19 starts with a minor. It's just like any other viral infection. Starts with a minor sore throat irritation. It could be totally asymptomatic too, or a mild symptoms in the form of upper respiratory tract irritation, running nose, fever, cough, just like that. In many of our patients, sometimes even do forget that they had an episode of fever, they had an episode of upper respiratory irritation or infection, by the time they land up with the problems with COVID. So it is very important that one keeps a track about when exactly was the onset of this prodromal symptoms that we normally call it. Prodromal symptoms. It's just a mild irritation or infection that happens. Okay. Um, this usually lasts for 2 or 3 days. In the meantime, the patient might have taken the opinion of a local doctor, or he might have subjected himself to home medications too, in the form of gargling, paracetamol, things like that. Okay, and then gradually, when the cough gets more and more irritative, when the fever spikes really start to trouble him, only then he approaches the doctor, and he thinks probably it could be COVID also. Okay, so this was, in fact, actually in the first wave, we have got two different patterns of patients reporting to us. In the first wave, there was a definite etiology, a history of being exposed to COVID virus either in the form of attending public functions or public meetings, or happened to meet someone who was later on tested with COVID positive. But here during the second wave, this particular incident is not commonly being noted. In the second wave, another important difference between the first wave and the second wave is the incidence of diarrheal episodes, which are happening more frequently with the second wave of COVID disease. Sometimes, rarely, some patients do present directly with myocardial infarction or heart attacks that we normally cause, or with neurological episodes too, directly into the casualty or into the emergency room also. Right. Now that we have a patient who has been having cough, cold, fever, upper respiratory irritation, and he decides that, okay, finally I could have had COVID, and then he comes to the hospital wanting to get himself tested. So what are the various testing tools that are available right now? The common testing tool that we call it as RT-PCR, or the swab test, or the COVID test, is the one in which they do a throat swab and try to find out the presence of virus in the nasopharyngeal area, or in the posterior, or along the posterior pharyngeal wall. Okay, and usually the RT-PCR test usually takes some amount of time before the result can be made available to the patient. In some situations wherein patients present with non-COVID problems to the hospital, these days the hospitals are subjecting these sort of patients to a rapid test, which is also known as RAT test, or the rapid antigen test, wherein the results are known immediately. Okay, but then this RAT test has got some amount of false negativity, but a definite positive RAT test is as good as an RT-PCR too. So there is no need to repeat. If one is RAT positive, there is no need to repeat a RT-PCR test. Right. In certain, what is being commonly seen in the second wave is that some of the patients, even though they manifest with typical COVID symptoms, still in spite of an RT-PCR, they come out as negative with RT-PCR. But I would like to put in a word of caution. If RT-PCR is negative, it really doesn't mean that the patient is not suffering from COVID disease. It only means that this particular test has not been able to detect the presence of COVID coronavirus in the upper nasopharyngeal tract. Okay, so if you are having symptoms which are suggestive of COVID, in that case, it's better that you confine yourself to home isolation, wait and watch how the things turn out. In case if you continue to have COVID symptoms, it's worthwhile trying to repeat an RT-PCR test later down the line after 2 or 3 days. Right. Okay. Or in case if the symptoms have really gone out of hand and you are really having breathlessness or a decrease in oxygen concentration, in that case you can directly straightforward subject yourself to a CT scan also for confirmation. Right. Okay. If the RT-PCR is positive, and now that you have proved that you are having COVID virus infection, right? So what do you do? The first and foremost thing that I would advise is one should confine himself for home isolation. This home isolation is supposed to be a very strict home isolation, and one should not come into direct contact with any of the family members. In an Indian scenario, what we commonly see is home isolation. During home isolation, patient remains within the home, but he will be having common meals with all the family members, or they will be sharing a toilet, she'll be sharing a kitchen. But that really doesn't constitute the home isolation. There is very high likelihood of spread of virus within the family members if one does not stick to home isolation in the proper terms. Right. When a patient is under home isolation, we would normally like to keep the patient monitored with for pulse rate, for temperature, for cough, for respiratory rate, and air saturation also, oxygen saturation. Many of these parameters can be taken care of with the help of a pulse oximeter. These days, finger probe pulse oximeters are easily available in the market and not very extremely high price too. So one can definitely afford for a pulse oximeter. So subjecting oneself to the pulse oximeter, we can find out the oxygen saturation, the heart rate, right? If the oxygen saturation at any point of time starts falling below 93 or 94%, then it is imperative that patient is going to go in for respiratory distress, or he's starting to begin the lung manifestations of COVID disease. Under these circumstances, the best thing would be for the patient to come to medical facilities, get himself evaluated, and do as per the advice of the doctors there. Right. Mm, when such a patient gets admitted to the hospital, in that case, we would subject him to blood investigations in the form of biomarkers like D-dimer, CRP, interleukin-6, LDH, serum ferritin, or even a CT scan can also be advised to him depending upon the severity of the disease. In India, we have got two types of CT scores done. One is usually out of 25 or other one is out of 40. Commonly the common one which we commonly use is the CT score for 25. Less than 8 signifies a mild disease, 8 to 15 becomes a moderate, and more than 15 onwards categorizes for severe infection. So based on this, the treatment will be accordingly depending upon the category 1, category 2, or category 3. So for continuing with the management of critical care patients, that is for category 2 or category 3 patients, I would now like to ask Dr. Rakesh Sharma to advise us about the medical management of such patients. Over to you, Dr. Rakesh.
Yeah, thank you very much. It's an honor to be in the same company as all of you. And before I say anything, I really feel bad for all the innocent lives that have been lost in India, where unfortunately medical healthcare system does not exist. I'm sure the government, central as well as state governments, will start paying attention from now onwards, because in future we might get more pandemics. As far as treatment is concerned, we didn't know much in March 2020 when COVID-19 hit New York. And as you all remember, it came here in March last year, and most of us were shocked, not prepared at all, and no one knew how to treat it. So we had very few guidelines, and no matter whether you looked towards Mayo Clinic, Harvard, Columbia, NYU, no one knew anything. And for months, they didn't know anything. And I'm not even sure if someone can tell me today that they know enough about COVID-19 treatment. So 10 of us here may have different approach to how to treat the patient. I am a little bit more black and white kind of person, and I will not say maybe and maybe. So in my theory, just like under treatment is bad, over treatment is equally bad. In short, in 1 minute, I want to tell to your audience, not to the doctors, people who are not in medical field, that having COVID-19 infection is not a death sentence. 80% people don't even need a doctor. They will get infection, they will do fine. Even if they don't see a doctor, they will do okay. So please don't think after getting infection that you are going to die. 20% people definitely need a doctor. And out of those 20% who get admitted to the hospital, only 5% will need ICU. And even in ICU, you have 50% chances of survival. So to scare people to death just because they have infection is not doing a public service. So now let's see, what shall we do once you have infection? As my dear friend just told how it comes, uh, everyone who lives in India must buy a pulse oximeter for the family. Even if you don't have a doctor, that's okay. Get a pulse ox. And if your pulse ox is 95 or more, I don't care if you have 101 fever, that's fine. Or if you have diarrhea, it will not cause any problem. If you have 95 and over pulse ox, you are fine. Don't do anything, please, except taking paracetamol and drink plenty of liquids. If you want to see a doctor, get few tests, great. Do you need to be in the hospital? Absolutely not. Don't waste your money and don't look for a bed if you have 95 or more saturation. You don't need any medication at all. We are only talking about people who have less than 95% oxygen saturation on pulse ox. As we all know, if you have 94 or less than 94 actually, only then you need hospitalization. So you have 90, 91, 92, 93, go to the hospital. 94 and above, don't even look at the hospital. Now, what do we do if we are staying at home with 95? Nothing at all. Please don't take steroids. One mistake that people are making in India is everyone is buying steroids when they get infection. There's no study that shows that you need steroids unless you are on oxygen. If you are not on oxygen, don't take steroids. Do you need oxygen if it's 94 or more? Absolutely not. Don't put yourself on oxygen. So what do we do now? 94 or less than 94, you go to the hospital, get admitted. So in mild disease, as you just heard, CT score, which we don't do in US, but in India, they have 25 or 40. When your CT score shows mild disease, but definitely infiltrates, that's when you need to be on oxygen and you need to take steroids. And if you have dexamethasone, please take either 6 milligram or 10 milligrams a day, just once a day. Why do I give these two different doses? If you don't have diabetes, please take 10 milligrams. If you have diabetes or impaired fasting glucose, means your sugar is running high, 110, 120, but you don't have diabetes, stick only with 6 milligram dexamethasone. You don't want to increase your blood sugar very high. And as we know, mucormycosis is being seen in India left and right, and that only comes in diabetic patients and those who have uncontrolled blood glucose. So diabetics should just restrict themselves to 6 milligrams a day of dexamethasone. If you don't get dexamethasone, you can definitely take prednisone, equivalent dose. If you are in the hospital, you can take IV dexamethasone or IV solumedrol. So that is about steroids. Don't take steroids just because you have infection. You must have saturation less than 94 and you must be on oxygen. Otherwise, don't take it. Coming down to antibiotics, no role of antibiotics at all. I am shocked when I see people getting 10 prescriptions and everybody's getting Z-Pak or azithromycin. Yes, we did that in March, April last year when we didn't know anything better. But now we know, and we should gain from our experience. Don't give any patient any antibiotic, including doxycycline. There is no proof it works. I want to tell people what not to do first. Same thing with convalescent plasma. There have been studies, including one in India, where plasma has not been shown to work at all. We were part of Mayo Clinic plasma transfusion in our hospital, and I gave it to 40, 50 patients last year. But this is when we didn't know anything. Now we know. No need to waste your time, your money, and look for someone to donate plasma. No need to take plasma. Now, coming down to what shall we do? If I keep on telling people don't take anything, they will say, what did doctor do for me? You have only 2, 3 things that you must take. One is oxygen. If it's 93 or less, only then you should take oxygen, and please take as little oxygen as possible. You want to keep your oxygen saturation, which you can determine with pulse ox, between 90 and 94%. You don't need to keep it 96, 97, or 98. Now, if you are in the hospital, same way, keep your pulse ox between 90 and 94. If you cannot with nasal cannula, please go on high flow nasal cannula. If that doesn't work and you must take non-invasive ventilator, which is BiPAP, CPAP, that's great. Worst come to worst, intubation. But saturation doesn't have to be kept more than 94%. So what else can we do? I know you all must be waiting for me to say something about remdesivir. We all have read everything about WHO and other studies. Remdesivir is the most controversial medication. And I'll be very honest with you. If I have 50 lakh rupees in India and I'm in the best hospital, doctor wants to give me remdesivir, take it. If I have 50,000 rupees only in my bank account, do not waste your money on remdesivir. It's not going to do anything at all. If it does something, you are a lucky person. So it only decreases length of stay in the hospital. It will not decrease your chances of getting on the ventilator. It does not have any effect on mortality. So please don't waste your money unless you have extra money and you must take something. So oxygen, steroids, stay away from everything else. IL-6 or interleukin-6 inhibitors have study after study have not shown anything. I used it for 2-3 months last year, but I have stopped using it at all. My colleagues, some of my colleagues in New York still use it. It's, I think, a medicine of faith, not of any experience shown medication. So if you don't have medication, no harm done, nothing to be taken. Oxygen, as we know, is a toxic drug. If you are on more than 60% oxygen for more than 24 hours, it is more toxic than helpful, but sometimes you need it and you need it. If you don't need more oxygen, cut it down as much as possible. In India, I know they don't have monoclonal antibodies. That would have been the best case scenario if you were obese, diabetic, or if you had underlying cancer, if you had chemotherapy going on, if you have chronic kidney disease or bad kidneys, you could take monoclonal antibodies as soon as you had infection, and that would have been the best thing. But as I know, they don't have it, so that option is gone. And treatment is for people who have less than 93% oxygen saturation. Go to the hospital, get the best doctor, not the doctor with 5 degrees, but the doctor who cares about you. The hospital that is not trying to make lakhs of rupees from you. That's what you need. You need a dedicated physician. You really don't need to be having a DM in pulmonary or critical care. A good MD medicine doctor can take care of you. And all you need is someone who really worries about you and not looking at how many lakhs of profit they can make from you. Unfortunately, I have to say that because I'm very upset from the stories that I hear from India. In US, I have not seen any doctor, making bundles from this pandemic, and Indian government really has to step in. A couple of other things before I go off. If you are on oxygen and your oxygen requirement is going up, please use proning position. Even if you are at home, lie down. This is for the public. Lie down on your stomach for hours and hours. That will increase your oxygen saturation. That will also distribute oxygen to your lungs properly. Because when you are laying down on your back portion of the lungs don't get enough oxygen because the weight of the heart and the way blood is distributed and the lungs expand. So if you are on oxygen, please lie down on your stomach for 4, 6, 8, 10 hours a day. You will feel much better. Your oxygen requirement will go down. And believe me, this is a free treatment. You don't have to pay anybody any money to lie down on your stomach. And that's better than spending thousands of dollars on remdesivir. Uh, if you have mild disease, keep on taking hydration, eat well, exercise a little bit, which means walking, not any other kind of exercise. Two other things. One is aspirin. Studies have shown, I know in India you have 75 milligram aspirin. The day someone tells you that you have COVID-19 infection, please take 75 milligram aspirin every day for a month or so. Cheapest medication will save plenty of lives. Now, at home, do you need any blood thinner? No, you don't. You just walk around every day for a few minutes in your house, even when you're under isolation. You don't need any blood thinner at all. In the hospital, you need blood thinner for normal, like a normal patient. We give low molecular weight heparin here, 40 milligrams a day. In what we did in our ICU, we gave 40 milligram twice a day. Does twice a day work better than once a day? I have no proof at all. We gave that because there's an increased incidence of blood clotting in COVID-19 patients. But even if you take 40 milligram once a day in a hospital, low molecular weight heparin, that is fine. If you can take twice a day, if you can tolerate, that would be better. Do you need mega dose heparin drip? Absolutely not. No indication. Do you need warfarin? Do you need a 10A inhibitors or newer medications? You will have a medical community divided 50-50 on that. My take is you don't need it. Even when you go home, if you're walking around, aspirin is more than enough. Don't take anything. I'm just shocked when I hear that people in India are dying of acute MI after COVID-19 infection. I seriously doubt that that's what is happening, that people are getting MIs left and right. I have not seen a single case of MI in my ICU in the last 1 year, and I've treated hundreds of COVID-19 patients. So if someone is getting MI, it has nothing to do with COVID-19 infection. They perhaps have underlying coronary arterial disease, so they should be treated the way any other regular person should be treated. I think I took more than 5 minutes of my time. I'm sorry about that, but I had to educate people that more treatment is bad treatment. Don't waste money left and right. And you don't need 30 blood tests. You really don't need blood tests anymore. Whether your CRP is high, whether your troponin is high, whether your D-dimer is high, who cares? The treatment is so limited in COVID-19 that all these mega tests that doctors are doing in India every week, treatment does not change. So why even bother doing those tests? You just want to know your kidneys are okay and your liver is okay. Thank you.
Thank you, Dr. Rakesh, and much appreciated. Very practical examples what you have given from your own ICU and your own cases, and that's really going to help all of us to understand here. Many of medicos and paramedicos are also listening to you, not only in Zoom but also on YouTube parallelly, and it's really 75 plus attendees are there, and they are growing more now. And I'll be also circulating this for sure YouTube on behalf of our team. The link will be going to all the attendees as well. I'll be requesting now Dr. Khushbu, as she also had been front runner for managing the ICU, many of those critical cases. Over to you, Dr. Khushbu.
Thank you so much, Dr. Bridge. And I again want to thank everyone for having me on this panel. Obviously, it's going to be very difficult to go on after Dr. Sharma has essentially covered a lot of the ground that I would have spoken about. But I did want to tell you, just as Dr. Sharma has mentioned very clearly, that I think that COVID has really humbled us, the medical community, because we really don't have a lot of therapies that are available. And so, because he kind of gave you a little bit of a background, I want to jump through the therapeutics just as he did. And before I do that, I wanted to kind of tell people, I think I hear this question a lot of times, even from my patients in the US and family members in India as well. The distinction between COVID infection and pneumonia. So first of all, I think it bears to weigh in is that COVID doesn't always cause a pneumonia, but when it does is when you start noticing the desaturation, the oxygen levels starting to go down. I think that's what my colleagues who came before me were talking about. I completely agree that there's oxygen. You start the oxygen therapy once you notice that the saturations are going below 94. They've done studies of trying to see should we start oxygen between 88 to 92% saturation when you measure it on your finger, or should we start it after 94 or between 92 and 95? And what they've seen is if you start it when it's lower than that, it has increased, it shows increased mortality, meaning that you may notice patients, their death may be more so. So you want to definitely key into that saturation of less than 94. So, 91 to 93 is when you want to kind of start moving in that direction. Secondly, steroids. I completely agree with Dr. Sharma on that. I think steroids need to be only used very strictly once given by the physicians, prescribed by the physicians. It shouldn't be a thing where just because a family member got it, that you should get it, because it has a lot of side effects. Not just the mucormycosis that we're all very afraid of now, but it also has other side effects, like just increasing your glucose. There's a lot of different things that come with steroids. So we need to be very careful in using steroids the way we do. Essentially, it should be when prescribed by a physician, not just because you know that you need to be taking it. The other thing that I would mention is, what I've seen and what we've used here in the hospital systems, in my hospital systems, for the data is that the 6 milligrams dexamethasone is something that has been studied in several, trials. Namely, Recovery, which is one of the bigger trials that we kind of seem to base it on. And it has been supported by others. It doesn't have to be dexamethasone when the physicians do prescribe it. It can be an equivalent. Also from hydrocortisone, it can be dexamethasone, it can be solumedrol, it could be any of those different segments as long as the doses are equivalent. We usually only continue it for 10 days. And if we see if the physician, the intensivist or the pulmonologist or the physician in the hospital decides that, okay, there may be a different reason why they need to continue or prolong that course, they may go ahead and do that. But that should never be a decision of, it should never be left to the patient to sort of do that. Secondly, I would say is related to the medications. Remdesivir, I completely agree with Dr. Sharma, is a medication that has been studied. It has been FDA approved in the United States. It was one of the early medications that we started to use. But the data only suggests, and the use should be early on. It's an early use medication, and it's suggested that you use it. It's suggested that it is used only to sort of shorten the hospital stay, really, and hoping that it would not lead the patients to go on to a ventilator or a BiPAP machine or the oxygen supplementation that we are talking about. If you do not have the money, you do not need to feel that that is a medication you have to go out and get. That is not something. The ones that have shown mortality benefit, when I say mortality benefit, what I'm saying is that have shown that can help people survive this disease, has been a steroid. And most recently, there has been a little bit of data on a medication called tocilizumab. And that medication has been put out there. It's now part of management per the NIH guidelines, even by CDC, but only in a hospital setting and only under very strict conditions, because the risks along with it, which include getting infections, we're not sure if it reactivates TB, so all those things have to be considered. So just because you hear that there's a medication for tocilizumab, don't just go out and get it. It needs to be very strictly monitored. It is only indicated when the oxygen requirements are higher, and which needs support in the hospital, strictly in the hospital. So there's no reason for you to have to take it outside the hospital. So that is one thing I want to make very clear, because I've seen, on the pages that I'm on, that people are looking to get tocilizumab from other places, and I just want to make sure it's under a physician's the physician is requesting it and that it's under their management. So that's important. I completely agree with Dr. Sharma about proning. I think proning is very important. Even in the ICUs, we have prone patients while they're on high flows. We have prone patients while they're on bypass. Now, per the recommendations, it is supported only if the patient is able to do it themselves. And sometimes our nurses help as well in the ICU to help them prone. But that should not delay intubation. There's a lot of fear of intubation. There's a lot of fear of death once patient comes to the hospital. Again, I think that it's a little misguided fear, as Dr. Sharma said earlier. But I think the reason we're seeing this death rate and that's been so magnified in India is just because the medical system is under pressure. And we had that happen here. We had that happen in New York. We had that happen even in Atlanta, where I am. We've had multiple segments where we've had spikes. So I think that is more not because of the disease in itself, but also the inability of patients being, getting access to medical therapies per se. Moving on from there, ventilator managements. I think that high flow, specifically, this is more to the physicians, but the high flow, I'm sure that a lot of patients have spoken about or heard about it as well. High flow has shown that it does prevent, by a small degree, a patient progressing to requiring a ventilator. So that is something that has been seen, that we have all seen. I know Dr. Sharma also mentioned that earlier. That is an important thing to, that is okay to have, and it doesn't equal to a death sentence. Okay, so it's okay for patients to be on high flows that have helped them to recover, and that has also helped them to avoid the ventilator pathway. Now, one thing that is very important for everyone to understand is that this disease is unlike any other virus that we have seen, or bacterial infections. Yes, there are some bad bacterial infections, but this is mimicking, one of a very serious disease process. And the reason I say that is the recovery is not as fast as we would like. Usually, if someone has a viral infection or a bacterial infection, we give medication and people just recover within a couple of weeks. That is not the course of this specific virus. I also do pulmonary, so I also do outpatient medicine. And in that, I have seen patients have symptoms, fatigue, shortness of breath, cough that is prolonged over weeks to months. So please do not feel that you should have improved in 2 weeks or 3 weeks, okay? And do not lose hope if your family member is in a hospital setting for a long period of time. It just takes a very, very long time for you to get over it. So that is very important for everyone to understand and hear. That please do not, feel defeated just because someone is on therapy for a long period of time. Okay, again, I would stress the importance of food. I would stress the importance of managing and monitoring blood glucose levels, just to prevent other infections. Definitely, please keep in on that. One other thing that I wanted to mention, for patients who have wheezing and who have chest tightness or who have this cough, and I think this is recommended also on the Indian guidelines, is the use of budesonide, which is an inhaled steroid. The risk of using an inhaled steroid is not as much as a systemic. When I say systemic, I mean taking the prednisone or dexamethasone pills. It goes in the entire body. This one is focused more on the lungs. What it does help, and it does in early on, when right when you're diagnosed, if you start noticing symptoms of cough and things, you can use budesonide that has shown to help patients very early on. Okay, and so that's something that you can use, and I know I've seen a lot of physicians prescribe that as well. Again, just one thing, and the hope that I want to give you all is We all will get over this. We did in the US. We thought it was impossible to get over. We were all, as a medical community, really depressed with everything we saw here. But we had a lot of help from outside. I personally did. I had, physicians that I would reach out to in Italy, in Germany, in different countries. And that is a hope that we have here, that we would be able to offer support to our colleagues in India and the patients there. I know Dr. Bridge knows I will answer my phone if you call me. And I have no issues doing that, because I know what we go through as a community. It is very, very sad to see patients dying, and that us, the medical community and the patients' families, not having any control over preventing that. So please feel free to reach out. We are here with you guys. All the Indian doctors are here to support you. And please, if you have any questions, I'll be happy to answer on the tail end.
Great, Dr. Khushbu. Thank you very much. And indeed, it's pleasure to connect with you online here as well as offline. With, of course, we have done so a couple of days ago, and we will do so. Basis, of course, all of your convenience, will not be barging into your privacy, professional or personal, and we'll ensure that. And many of the questions are coming up. I think that's making the things quite interesting, as some of the patients, they are really in need of some of those good advice from all of you, and it is coming on the chat. I'll be coming to these questions for sure. So stay tuned. I request each one of you, and a couple of the attendees are on YouTube. I request all of you also post your questions. Keep posting it, and we'll be answering them shortly. Many questions they have come up. So I'll be requesting now Dr. Samar and Dr. Lalita. This is vaccination is a very hot topic. It's a topic where we have much of knowledge spread on the social media, government agencies, NGOs, and many more. So we'll be also requesting Dr. Chandrasekhar to join on this. From Chikmagalur, he has been managing hundreds and thousands of patients from last year, and he'll be moderating with both of you and to discuss on this vaccines which are available globally. So first, to listen from Dr. Samar and Dr. Lalita after Dr. Samar, and Dr. Chandrasekhar to moderate it.
Sure. Thank you, Bridge, very much. Lalita, we can talk together. I think I agree that I think vaccination is probably right now. Obviously, the symptoms and the treatment are critical, but I think that in terms of getting India forward and moving out of this second wave, a vaccination is critical. I'm just keeping an eye on time, and I think for vaccines, I think probably question answer is a more effective format than trying to lecture on different mechanisms of vaccine production. So as you know, they have Covaxin and Covishield in India. There are discussions now of some of the other vaccines being improved. Honestly, I'm going to defer to Dr. Darba if she wants to talk more, but I would say really, one message I want to give everybody on vaccines: just get one as soon as possible. There are questions about safety. There are questions about, is it protective for new variants coming from India? All of these are good questions. All of these must be need research. We are doing the research. I'm telling my family members, I'm telling myself, my cousins, my mother, my father, that absolutely the best thing you can do to protect you and your community right now is to get a vaccine as soon as you're able to get it. And all other concerns are something we should continue to discuss, but safety-wise, that should be the priority. So that's really my main message. And then if Dr. Dabra wants to add, and we can obviously answer questions if people have more technical questions about vaccines.
Thank you so much, Dr. Mehta. My take-home message was the same as Dr. Mehta's. Interestingly, we both have the same message for the audience, which is any vaccine is better than no vaccine. So in interest of time, as Dr. Mehta pointed out, we had a couple of questions that were forwarded to us, and I picked up the 3 questions related to the vaccines, and I will read the question and the answer so that it's recorded in the session. So the first question was, there are many vaccines in the market. How do we decide on the best vaccine? So the answer to that is, gather your data and information. Please, please, please talk to your doctor and your healthcare worker and discuss all your queries. Discuss at length. Even no question is a small question. Get all your questions answered, and then you make an educated choice of which vaccine you're going to take among the options that are available in India. The next question is, which vaccine is approved for children and what are the chances of getting it in India soon? So the answer to that is none is approved as of yet, to my knowledge. And the safety and efficacy of adult vaccines are being assessed in the trials for this age. So again, I'll repeat the key message. Children do get the severe disease, even if it is small in numbers. Thus, there is no harm in considering vaccination for them. The safety and efficacy, however, are being assessed in trials for this age. Now, moving on to the last question, which is, any adverse reaction from vaccine can happen and how to prevent it? So this is a question universally that comes over all over the world. And the way to address this is there is something called a Vaccine Adverse Event Reporting System, which is called VAERS. It may be named different in different nationalities and countries, but basically once you get a vaccine, the vaccine provider, you'll have to stay in touch with them, stay in tune with them, and any event that is occurring after a vaccination has to be reported. If you believe that symptom is arising after the vaccine has been administered, please report it to your provider, the vaccine provider from where you took it. So that way it could be recorded and that event can be investigated. So those were the 3 questions that were received. We are happy to take any other questions that come up on the forum. Thank you, Dr. Mehta.
Fantastic. Dr. Chandrasekhar, you're on mute, sir. So please unmute.
Yeah, thank you, Dr. Lalita and Dr. Samar. From the Indian perspective, yes, I definitely agree with you. Any vaccine is better than no vaccine. Definitely, that is the message should be loud and clear. Right? In India, we didn't have much of a choice regarding which vaccine to select initially. It was just that whatever was available was offered to us. Covaxin was available to most of the health workers because it had not yet passed the trial 3 of the clinical trials. And subsequently, Covishield was given to the elderly patients more than 65 years in the first stage, and subsequently it was offered to 45 to 60 years age group. And now even it is being offered to 18 to 45 years age group also in a staged manner. I think there is very little to differentiate between these vaccines, between either Covaxin or Covishield. Both of them are equally good enough. Yes, in terms of statistics, in terms of percentage, there may be few positives and negatives, but still, yes, message is take vaccine, whichever is available to you, as early as possible to be safe from COVID.
Thank you, Dr. Chandrasekhar, Dr. Lalita, and Dr. Samar. Wonderful news coming up from 3 of you that vaccine is needed. Do not delay it. Take it. Don't look for the options. And even a single minute counts. And I can share my practical experience. I had the COVID in last year. 9 days I was admitted in local hospital in Bangalore. And everything was tried. Remdesivir was tried. Every antibiotic was tried. Oxygen was tried. But the best thing which worked was spirit, the moral. If spirits are higher, yes, oxygen, any of those cares certainly help. But most important is that nothing would happen. You come out of this. Immediately after that, the vaccine was available after 2 months, and I went for vaccine. There was a second exposure to me, and I was having not much symptom, where my younger brother and his whole family, they were in serious crisis. So that says a lot, where I took only Covishield, against which a lot of news have been spreaded, but I took that without wasting time, as I understood gravity of that matter. So it's loud and clear from 3 of you that go for vaccine, do not delay. Thank you once again. And I would like to take help here. Dr. Arun also is joined. Dr. Mata Arun, can I request you to briefly tell your experience in not only in US, globally, how exactly you have seen this COVID second wave, which is controlled by US and a couple of countries, how differently at Indian citizen level, we'll not get into the policies and to the infrastructure and all, but how the message loud and clear can go to all of us on top of what we have been discussing now.
Need to unmute. Can Soumya unmute Dr. Arun?
Dr. Arun, you are audible. You can continue. Dr. Arun, you're audible.
No, I think he has to unmute himself. Yeah.
How about now? Am I good?
It's better.
Okay. Are you able to hear me?
Yeah.
Yes, sir.
Perfect. Okay. So thank you very much for allowing me to participate. I think this is a crisis time for India. No matter how many suggestions and how many reassurances people get, people are scared that once it's them, what am I going to do? And especially when the resources are scarce, it makes it even more complicated. So the best thing I think is, you were doing well and you got the second wave, and people blame on many public gatherings. We don't know, but the what to do currently is, the first thing is to be courageous. I saw a post yesterday which was very interesting. They said the deer runs at 93 miles per hour and the tiger only runs at 56 miles per hour, but yet the deer succumbs to the tiger because it's always looking back and seeing if the tiger is approaching closer to the deer. So that kind of scare and distraction, even though the deer is faster than the tiger, it gets captured by the tiger. So you have to be very alert. You have to do certain public health measures. Like, they say there are no clinical trials or studies to say what kind of mask, cloth masks or different types of masks, the surgical mask, the 95 mask. Nobody has done a clinical trial to say which is more effective than the other. But we know in a public health measure to prevent droplet infections or to prevent, contacts spread through air or droplets, we use masks. And they're saying use a double mask. The first mask is a paper mask, the second mask is a cloth mask, whatever. I think these things don't cost us anything. I mean, if it works, it works. If it doesn't work, but at least we did what may have worked. So I think wearing the mask, maybe even double mask, when you have to go out and interact in places where you buy grocery or whatever, so that's number one. And wearing it properly, a proper fitting mask. You need to make sure that your nose and nostrils are covered, your mouth is covered. It is not a theater, it's not a show. So you need to protect your nose and your mouth completely, and it should be closely fitting to your chin and your cheeks. The best thing is to follow certain good hygienic measures. It's not just for COVID, for any hygienic measure. When you these are practices established in India. When you go out and you come inside somebody's house, you are asked to leave your footwear outside so that you don't bring the germs from the dust or from outside. That is what everybody is saying now. When you enter a house, try to keep your footwear outside, and then you wash your hands and feet thoroughly. To everybody's knowledge here, I am still using the Synthol soap for 40 years, even after I have left India. I buy Synthol soap here and I use the Godrej Synthol soap. So use any soap, wash your hands. Any soap works. It doesn't have to be imported. Your local soaps are in, as I said. So wash your hands thoroughly for 5 minutes. Run it under the water. After you have, touched certain areas, there may be contact with saliva or contact with nasal droplets, or any exposure to any substances which is not really clean and dry. Now, due to time constraints, I'll quickly touch on mucormycosis. As Dr. Sharma mentioned, this happens, fungus attacks when there is moisture and there is dryness, dry heat. I mean, not dry heat, there is moisture and heat. So fungus is prevented with cool and dryness. So you have to ensure. I mean, they asked me about steam inhalation. I think it doesn't hurt. I mean, many people used to do steam inhalation. When I was a little kid, when they said you got a cold, they said put Vicks vapor up in your water and boil it and inhale it. It will help you. Whether it helps or not, at least it helps your nasal passages. It helps, it keeps it dry. So it cleans up, it prevents infections, secondary infections, or it might prevent, the dryness, and it might prevent it might help clean your sinus membranes clean. The other, public health measures we all know is that, you don't want to drink from the saliva or the air droplet contact. Try to use your own cups, your own utensils, and all those. There used to be something called the muddy or orthodox. They used to do, people used to do. So if you follow some of those things, I think it will come in handy at this time of that muddy behavior will help. So with that, I will stop.
Great, sir. Thank you so much, Dr. Arun, and wonderful speaking to you. And thanks that you're sitting next to the beach and helping us also getting the good cool breeze coming to Bangalore and part of India here.
Yes, thank you.
So love to also listen briefly from Dr. Shobha. Despite of her not so good health, she could get the Sunday morning with a good coffee. So how about some of those cases where the very important organ, the heart, so that gets impacted during this COVID exposure to the patients. Some are symptomatic, some are not symptomatic. But what are the things we should take care of, Shobha?
Thank you, Dr. Braj and the whole panel. It's really nice to be here. And I think Rotary Yelanka Bengaluru has really set the bar high within a week to put this all together, and very much needed awareness. And we learn from each other too, the specialists in the whole field of medicine. So thank you, and wonderful listening to everybody. Now for the cardiac care in COVID patients, we started to see it like Dr. Sharma was mentioning last March, after the Women's Day, March 8th, when I gave a community talk on women and heart disease. That's the last meeting that I attended in a public setting. After that, it was complete shutdown, and we did not step out after that. And we found, the cardiology community has found 50%, close to 45 to 50% reduction in all acute MIs. It could be ST elevation MIs, non-ST elevation MIs. There was a 50% reduction. We thought it would be the contrary. We got a lot of high blood pressure patients on telehealth visits. So it started that way. And, now there are a lot of registries going on as to what could be the reasons for it. So that is one end of the spectrum, how it started. And then as the disease evolved, we have much more insight, and definitely, like already alluded to, we definitely don't know the entire spectrum, but cardiac manifestation is certainly a spectrum. It could be that almost now MRI studies are emerging from Germany. Almost 75% of patients with COVID, even those who have not been hospitalized, have some form of affection to the heart. The heart is involved in some way or the other. They could be entirely asymptomatic, or definitely they could have other symptoms. Now, the focus is, of course, on the lungs. And I want to say that all the lung specialists, I mean, they're saying the ones with severe COVID, it looks like a bomb blast went off inside the lungs. They have not seen anything like this. That is what's happening to the severely ill with COVID. Now, whatever happens to other organs is more a ramification of that. There are two types of heart attacks. One where there's a clot, an acute rupture of the cholesterol plaque inside the artery, and then the platelets stick to it to cause, I always tell patients the analogy, it's like an 8-lane freeway. Suddenly a boulder falls across and stops your traffic completely. That's an acute heart attack with a clot. But there's a type 2 where there's just a demand supply mismatch. And like Dr. Sharma already alluded to, that's the one we are seeing much more. And where there is evidence of damage, however, it's not because of the traditional acute clot plugging the heart artery. So when I want to put it in two perspectives, in hospitalized patients and then the ones that are not hospitalized. The most common reason we get called is elevation in troponin level. And also abnormal echo. So the residents and the internists and the intensivists have already ordered, the blood work to check if there's any myocardial damage. With troponin, there's a marker called troponin. It's a protein that lives, it's part of the heart muscle. So that is released into the bloodstream, then there's heart muscle damage. So because it's elevated above the 99th percentile of its normal, we get called. However, initially we were scratching our heads. We would get an echo. It could be variable. It could be normal, good pump function, or it could be weak in certain areas. However, at that time it was raging. I mean, patient is completely COVID. We would wear the caper and we would go in, and EKG may or may not show acute changes. And the decision had to be made. Do we cath this patient or not? Initially, it was conservative measures if the blood pressure was stable, if the patient himself or herself did not have any chest discomfort, or you give some nitrates and you could take care of it. You say conservative management if there was no ST elevation MI. And if there was ST elevation MI, it was a case-to-case decision, and we would go more towards a PCI because when you go in for diagnostic, you could also find, left main disease. So that's how the initial evolution happened, but routine care, definitely aspirin, definitely, if they tolerate beta blockers, yes, nitrates. So you give all of that and have supportive measures. Now, in case of when they get worse, there's severe inflammation, and inflammation of the heart muscle itself can happen. There is direct attack by the virus on the cardiac myocytes. Maybe a little less than what we see in other virus infections, but there's also a lot of inflammation being poured, lymphocytes and into the macrophages, what we call the interstitium, or the space between the cells. So the virus is not directly attacking the cell in large numbers and causing it to disrupt. That one pattern happens, but more of it is when there's a lot of inflammation pouring in. That goes with the cytokine storm, the IL-6 surge that happens, and the inflammation, and that means lymphocytes, neutrocytes, all the body's protective cells are kind of coming in and attacking. So that is what weakens the heart. And then we see the continuum. The bad end of the spectrum is when the heart just is not able to pump at all. We just get echoes of EF 10%, 5%, hardly moving hearts. And that means they're on 2-3 different varieties of pressors to artificially keep the blood pressure up. And then they're intubated. Their FiO2 is 100%. So that's when you make a decision. Hey, do I need to, give ECMO for this patient?
Yeah,
that's a very, right? I'm sorry. Are you running out of time?
I think what we are coming up with a lot of questions, Dr. Shobha.
Oh, sure.
One of the questions, one of the question, I'm sorry, I wanted to bring the question to you is that the person is asking that if any of the chest pain happens in a COVID patient, the chest pain usually happens with a heartburn as well as stomach ache. So how the person needs to differentiate as a, today, if one small problem happens, we think that it could be very, very fatal. So what should be the immediate, remedy, or at least an advice a person should do to differentiate these two? This is a basic question, but today it is very, very relevant when we are not having enough exercise, we are not going out of form, and we are also eating whatever we want to eat. And there are chances that lot of rasam, lot of sambar, lot of idli and vada, which I love it, and certainly it is bound to make some sort of acidity in a common language. So if you can help us, what should we do in such type of situation?
Thank you, Bridgie, and very, very relevant question because, and I would say even in the pre-COVID era, please don't ignore any chest discomfort. Southeast Asians in Indian origin definitely included. First, you want to make sure that the heart is in good shape. I always tell patients, you can always sit back later, scratch your head and deal with acid reflux, but time is muscle. Time means the difference between life and death. So never ignore the chest discomfort. If you first have it, remember heartburn got its name because of a reason, that it could be heart related, right? And many present that way. And be very cautious if you're diabetic, you might present with heartburn or no burn, no just discomfort. When you notice that, please take 4 baby aspirins. That's what we advise out here. 75 milligram. I know in India here it's 81 milligrams. So 4 baby aspirins and see if that would take care of it. Now, please don't self-diagnose, my humble request. It also depends on your risk factors, family history, early heart problems, diabetes, hypertension, and then right away, see if that goes away. And then if it goes away, that's wonderful, but don't stop there. Talk to your primary care doctor. You need to get a stress test. You need to check your cholesterol level and see what kind of things make this chest discomfort worse. This I'm saying in a non-COVID environment. In a COVID environment, it could be demand on the heart. It could be like a semblance of what we call heart muscle damage. It could also be a blood clot because there's more clots happening in COVID. So it could be a blood clot. It can also be a little bit of inflammation of the what you call the coverings or the pericardium of the heart. That's called pericarditis. So you would need to, I would really recommend, if you have any chest discomfort, please get it checked with a medical practitioner. You might, it could also be pleurisy, for all with the pneumonia going on. So it could be lung or it could be the heart. I would say, don't think, we always tell patients, I really hope this is acid reflux, but let us make sure your heart is in good shape. Because we lose patients. Time is so important, we lose patients. So do not assume that it's the heart. It's heartburn from stomach acid reflux. First, make sure your heart is in good shape. And to that, as an extrapolation, I wanna also say 75% of patients who don't require hospitalization for COVID, I think we alluded to, may still have effects on the heart. So it's important. You could have recovered from home. Researches are going on as to how we have to go about. Do we recommend, echo for everybody? Do we recommend, a Holter for everybody? That is going on right now. If I see patients who've recovered from COVID, they come back with chest pain. We do an echocardiogram. We do check blood to make sure that troponin is still not remaining high, and make sure there's no rhythm problems with a Holter. And then if they have the right risk factors, we put them through a stress test. Because this might be a precursor for actually sniffing out early heart problems. So this is like it's a big, I would say, a big spectrum of heart disease going on. However, I'm seeing a lot of folks with very severe LV dysfunction. And we do have to, if they are above a certain age, we do directly just cap them, make sure they don't have blockages. And I also want to say anyone with pre-existing heart disease and heart failure, very high risk of passing away. So do not take it lightly if you have pre-existing cardiovascular disease, and the troponin, the higher the troponin, worse the outcomes. So that has to be checked right away. That way you can be risk stratified and say, you're a high risk, we need to really aggressively treat you. So that is kind of the whole spectrum, and any specific questions about the heart, I'm happy to answer.
Amazing. I think a lot of questions are coming up like this, and Dr. Shobha has so simply, given and very good terminologies where we all can understand so easily. Thank you so much, Dr. Shobha. And love to host you for some rasam whenever next time you're here. Lovely rasam. So here, coming back, this is very interesting to see those questions, and I'll be taking up those questions in just 2-3 minutes more. Very connected is how about neurology? We have a lot of things which are coming up, whether it's not about only heart. whether any ischemia is there for the brain or any of those nervine tissues, where Dr. Krishna Prasad, he's a renowned neurologist with us. Dr. Krishna Prasad, very briefly, what are those things in next 2 minutes, if you can help us understand what are coming up today during COVID impact?
Thank you for inviting me. I mean, I should congratulate Dr. Shobha Choklingam for giving the cardiac perspective. She has virtually taken us by storm. So I have very little left. So the heart is, I hope your heart has always ruled over the brain. Now let us see whether the brain rules over the heart. Now, somehow I've not been able to work in the COVID, intense COVID area or the ICUs with a lot of neurological problems. Though the common problem that has been mentioned in the Indian studies and observation that are made has been the stroke as the foremost thing. The strokes have been hemorrhagic, which is more common, which is a blood leaking into the brain. Next is ischemic, or where there's a blood clot leading to a stroke, and some other manifestation. These are some of the things which can be catastrophic or can be following a COVID infection. This is what I've heard and what I've discussed at personal level with the ICU people. That's one. Second thing is about in the acute setting, during a mild infection with COVID, people could be having myalgia, though it is an integral part of any febrile illness, more so of influenza or flu, what we commonly call, and also corona, an unusual myalgia which is seen in many virus infection, including the Coxsackie infection, which is not often diagnosed other than clinically. And similarly, other than myalgia, the loss of smell, because it is said that the corona enters the brain or the system or the human body through the respiratory epithelium, which is the nasal cilia, and that could be damaged, and the olfactory nerve, and then the loss of taste. So this is some of the thing, and also not only the loss of taste and the smell, it's also about an abnormal smell and a taste. Recently, my cousin who had an acute corona infection, no, not severe, had sore throat and undue myalgia, and along with that, he said his food tasted much more. The salt tasted much more than the usual. Similarly, the sweet also tasted much more than the usual. These are some of the unusual, which I also heard in some other patient. This is one thing which we often see. There are a few things that have been described. One is stroke, as I mentioned to you. The other one is spinal cord manifestation, where the spinal cord could be involved in the inflammatory process, producing what is called myelitis, transverse myelitis, or something simulating what is called a acute polyradicular neuropathy, or the GB syndrome, what we call. This I recently heard in one of the patient, an elderly man who was vaccinated. Just after the second dose, he was over 80. After a day or two, he developed progressive acute flaccid paralysis, and he had to be hospitalized. And surprisingly, he turned out to be seropositive for corona, and then he succumbed to the illness, because not only, even otherwise also, a GB syndrome has a very poor prognosis in elderly people, more so if they're diabetics, they go on to the ventilator. And the other manifestation, the psychiatric manifestation, which is anxiety, depression amongst the patients who got mild infection once they are in the recovery, and also in the attenders or the relatives who become very anxious because the patient gets into the ICU, they see the news, TV media, all that, pouring in and day out, which results in undue anxiety, and some people may have neurotic symptoms. And this could also lead to, a sudden cardiac death or sudden cardiac arrest, which could also contribute to other, morbidity and mortality seen in non-COVID patients. So the corona patient on the recovery also, I've heard a couple of patients landing up with stroke in spite of being an anticoagulants, or what's the modernly used, of late people have been using a novel anticoagulants, or the NOACs, as they're called in the medical fraternity. And these particular patients have been switched back to aspirin. So there could be multiple factors which could be causing. One is, it could be a cytokine storm, it's a disimmune response, and endotheliopathy, which could be responsible other than the disseminated intravascular coagulation, which could have an hypocoagulable state, or a patient who can have microthrombi in their blood vessels producing small micro strokes in the brain, and also can also produce bleeding manifestation because there's a hemorrhagic component to so-called disseminated intravascular coagulation. So these are some of the things, even the general physicians keep facing people who are unduly anxious because they may get the role of the vaccine, but they have not received. They have just received one dose, but the Covishield is better than Covaxin. These sort of dilemmas that keep on going amongst the general public, more so people who have been affected, and they become probably hypochondriac to an extent wherein they, this is what, in spite of all the precautions that they take, that is how this pandemic has made the general public. And
Absolutely.
as I told you, needs to be educated, to be reassured. And probably this particular series goes in a long way in doing so, and also exchanging the ideas. And probably neurology has been set in the backyard with pulmonary and the kidney manifestations, and then to an extent the cardiac manifestation.
Dr. Krishna Prasad, I can vouch that brain rules every organ, and
brain obviously rules. Without a brain, only a heart can be functioning, and the brain has to function in its best. And I think right now what we are all talking, because the brain is functioning optimally.
Absolutely, and there are a couple of questions which are very interesting, and I'll be taking up them now. In meantime, just very briefly, Dr. Shubhashri, you have been really working hard during this tough time and getting settled in US, and from this land, great Karnataka. What do you see the difference? You must have seen that the shield, the shield what we use the mask, we use a very good way of cleaning our hands, not touching the surfaces. Despite of that, what exactly we need to have a cultural change, a shift in our habits here, so that we don't get into a severe third wave. What is that prevention you would like to advise?
Thank you so much. It's an honor to be a part of this panel. I've learned so much from this webinar already. So everyone's already mentioned this, but I like to say that whatever happens, whether you're vaccinated or not, whether you've already contracted COVID in the past or not, you should continue to follow the 3 W's. So that's wear a mask, wash your hands, and watch your distance. So wearing a mask, as Dr. Arun said, it doesn't matter what mask you wear. It can be an N95, it can be that normal blue color mask, the surgical disposable one, that's okay. If you want a double mask, you can go for that. A cloth mask covering your nose and mouth and chin, that's fine too. As long as you have something tight enough, which is covering your nose and mouth, you should be fine. And obviously it shouldn't be falling off, and you shouldn't keep taking it off and putting it back on. Those are all big. The whole point of wearing the mask is doing. So there's that. And this mask, well, obviously you're supposed to wear it when you're outside. But if you happen to be COVID positive and you're quarantining at home, or you've come in contact with someone who is COVID positive, or you're COVID negative, you have the symptoms, you should be wearing a mask at home too. So that's about the mask. And washing your hands, everyone's already mentioned it, but you should wash for at least 20 seconds. Soap and water should be fine. If you don't have soap and water, alcohol-based sanitizer is also okay. So you should do that multiple times a day. Yeah, your hands are going to be drying up, but that's okay. It's better than getting COVID. So 3, 4, 5 times before meals, after meals, whenever you can get your hands on soap and water, just keep washing your hands. And walking distance, avoid big crowds, avoid going outside, maintain distance when you are outside. So those are the basic things I would say. But regarding prevention of COVID and potentially, I would say, as Dr. Lalita and Dr. Sama mentioned before, to get vaccinated. It doesn't matter what vaccine, get some vaccination. COVID. And one thing you can also incorporate is immune boosting food in your meal. For example, you can start adding more turmeric in your meals. Honey is also a very good immune boosting agent. And you can also supplement with vitamins and zinc, which are also very useful. Especially, I believe many trials are showing that vitamin C is very good at immunity. So I believe there's Lindsay, that's the brand name. You can take that once or twice a day. It will only not cause any harm. It's after all the vitamins.
Great.
So those are also very useful. Other than that, I don't know. I know people are getting frustrated because many places in India are in lockdown right now. And India has been going in and out of lockdown for so long. It must be very frustrating. Thankfully, it's not like that in the US.
Yeah, exactly.
My
I think
friends are studying for
you are
exams and
right.
working right now. They're having a tough time, but just wait it out and things will get better for sure. I guess that's what I would have to say.
Great. Thank you so much, Dr. Shubhashri. And I think Dr. Lalita has a quick comment. You're on mute, Dr. Lalita.
Yeah. Thanks, Bridge and Shubha. That was wonderful. You gave a very good, effective message, I would say. I just wanted to add or share a quick point to everyone that the lesson, this session is great. And then I think the main purpose was to translate what we learned in US, how we can best help the India situation. And one thing that I wanted to share was with effective masking over the last year in US, there is a remarkable decline in cases of flu, which is like a collateral benefit. We were thinking of reducing COVID infections, but with effective masking, the incidence of flu that happens every year came down. So just wanted to, reiterate what Shubha said about effective masking. Watch your step, wash your hands.
Great. Thank you so much, Dr. Lalita. And we quickly go to very important questions which have come from the team. I'll be requesting the first question which has come is after 25 days, it comes from Ravi, that even after 25 days of infection, still he's COVID positive. So what can be the quick region? Maybe can I request Dr. Samar if you're online?
Bridge, Dr. Mehta had to leave, but I can answer that question.
Sure.
Can you
Please.
just repeat that? Somebody else is that I'm multitasking. I'm admitting people here too. Sorry. Okay. Yeah. So
after 25 days of infection, still Ravi is positive for COVID. Any specific region he is positive?
see, the specific reason could be, the studies have been done, and then the virus could exist in the respiratory tract, to the best of my knowledge, up to 21 days in the respiratory tract. Correct me if I'm wrong. Other panelists are welcome to chime in. So how does he know that it is still there? Did he get a test done at 25 days? That is the question. And again, with that test, whether there is a false negativity. So the take home message, from the panel I can give is he has to follow up with his primary doctor.
This is Rakesh Sharma. Can I answer that question?
Yes, sir.
Okay. From all the studies we know, once you get infection with COVID-19 virus, after 2 weeks, virus is gone from your body. What you are seeing is a legal question. People have been testing the same patient again and again. We see that very frequently in our hospitals here in US, because patients have to go back to nursing home until they are negative. Nursing homes will not take the patient back. But in true sense, no one should get retested after 14 days of initial infection because virus is gone. What you are getting is that virus, which is still found in the nose. So practical solution is don't ever test yourself again after 2 weeks of infection. In fact, once you're positive, don't test it again. So you are just picking up that virus in your nose. Ignore it, please.
And watch for any clinical symptoms. The point that needs for the patients is, look for your symptoms. Unless there is a symptom, don't worry too much about it.
And once you are infected, you are not going to get reinfected. Your own body antibodies will be good for at least 3 to 6 months. So testing after 2, 3, 4, 5 weeks is of no use. So don't test. And if it comes positive, ignore it, and you cannot transmit that virus to anybody else.
Very, very important message. I think most of us as a layman, we do that mistake. We feel that the infection is still around and we might be infecting many of the people. And this is the awareness which is coming up through this session. I'm really appreciative of Dr. Rakesh, Dr. Lalita in contributing to this. And the second question that goes here, that oxygen saturation is varying for last 10 days. Platelets are going low. What is the suggestion?
Is there any specific number of saturation and the platelets?
Not really, but as a general thumb rule, if you can help, that'll be good.
Okay, so as we know, I don't know about India here, we count 150 to 350 as normal platelet count. So technically 125 could be low platelets, but 10,000 is also low platelets. So if your platelets went down slightly, means 110, 120, 130, not a problem. We have a joke here in US that if your platelets are more than 90,000, you can get brain surgery done. So you don't have to worry about platelet count of more than 90,000. So slightly low platelet could be consumption. That's what we call platelets can be destroyed by bacteria or by virus. That's called consumption, decrease in platelet count. So nothing to worry about. Yes, I would definitely be concerned if it goes below 100,000. Number two, if you have been taking any heparin or low molecular weight heparin, that can cause platelet counts to go down. And as we know, it's called heparin-induced thrombocytopenia or HIT, that normally doesn't come before 10 days or so, unless you have been previously exposed. So if you have been taking heparin or low molecular weight heparin for more than 10 days, platelets go down, and that will be very serious. That's where you need to see a specialist. And there was another part of the second question, something else went down.
The oxygen saturation, I think
Yes.
that would be.
Yes.
Yeah.
Oxygen saturation will fluctuate. In fact, if I take my oxygen saturation 3 times a day, like blood pressure, it's not going to be same. So if your saturation is 95 and above, don't worry and don't see any doctor.
Correct. Thank you so very much. It's so simple. And the next question goes here, that those people who have taken vaccines, can they be still potential asymptomatic carrier for the virus? Dr.
I can
Chandrasekhar would like. Yeah.
I can answer that question. I'll take 2 minutes. Once you have vaccinated properly, means 2 vaccines, after 2 weeks, you still have 10% chance of getting infection. Can you be infected? Yes. Can you be that symptomatic? Not really. You will have mild infection. Can you have pneumonia? Absolutely. I had one patient 3 weeks ago in my ICU who was fully vaccinated, had very diffuse pneumonia, and had to be put on high flow nasal cannula. That's the only patient I have seen in the last 5 months since we started to give vaccination in US. But I have another friend of mine, my good friend, classmate in medical school in India, who had fully vaccination done, was ill and had mild pneumonia on CAT scan in India, but he did very well. So normal rule is if you are vaccinated, you will have a mild case and you will have good oxygen saturation above 95%. Hopefully you will not require a hospital.
Perfect. And the next question goes that Miss Matilda is asking that her husband took the first dose of Covishield on 24th March. He had fever on May 1st, just a couple of weeks ago. And they did RT-PCR, which was negative, but he had fever for 7 days. A second time also RT-PCR negative report, but on 18th, he had massive heart attack and he passed away. I'm sorry, Ms. Matilda, I'm sorry to hear this. And doctor says the report is wrong. How is it possible?
Oh, let me take that. I was actually typing that answer. So there are a couple of possibilities, okay? And I'm very sorry that this happened because one thing is fever, but then do I understand right, the RT-PCR, the tests were negative and then they had an MI May 18th. Two possibilities. One is, don't know the age of your husband, Mrs. Matilda, but it is possible that he already had a blockage pre-existing, coronary artery disease. And then with the stress of this whole episode, plaque ruptures and actually had a regular acute MI. The other possibility, I don't know his echo, I don't know if he had an angiogram or anything, where the arteries remain, unblocked. That's what Dr. Lalita was alluding to, the Takotsubo, where it presents like a typical heart attack. And then we take to the cath lab, the arteries are open. There's no significant blockage. A significant blockage is 70% or more. So if it's 40 to 60%, we may do what's called the FFR to see if it is significant, hemodynamically. But otherwise, for all practical purposes, anything above 70%, that's when it's an actual meaningful blockage that we fix with a stent. But then in Takotsubo, the stress-induced heart problem, heart attack picture, the arteries are okay. There is maybe 20%, 30% blockage, little cholesterol here and there, but there's really no actual blockage. And then the heart function is only about 1/4, EF of 10%, EF of 20%. So normal is 60%, by the way. So it could have been either one of these. So it could have been the stress of the whole situation. We are seeing it with the RT-PCR negative, twice, I know, then, this could have been an actual coronary event. An actual heart attack also, because that is prevalent too, and then stress triggers it. We are seeing that, this kind of stress so it's important everybody just be very, very take a deep breath, do your pranayama, yoga, just be grounded, please. Otherwise we release a lot of stress hormones. So cutting down that anxiety and awareness is such a huge deal. But my sincere apologies for you, Mrs. Matilda.
Thank you so much, Dr. Shobha, and our prayers with you, Mrs. Matilda, and all your loved ones, everybody here. Yeah. We keep them in prayers. And here, I request one of very good question. It's coming up, and I request Dr. Chandrasekhar, sir, you have seen that lot many cases in your ICUs in Chikmagalur, and you have been working day and night to support your COVID patients in and around Chikmagalur. How do you see that this trend is going down, or what exactly is happening? As I see a lot of queries earlier coming up for bed availability in Bangalore and around in Karnataka, but now somehow those panic calls are reducing, or is it only some of, you can say, tip of iceberg I can see? Maybe something else is there down deeper. Over to you, sir. Can't hear you, Dr. Chandrasekhar.
Yeah, I was muted actually. Yeah, right now, the situation is not the same as what it was a couple of days or even a week ago. We had a lot of patients demanding for beds, and unfortunately, our beds were full. We were not even able to forget about offering ventilators. We were not even able to offer oxygen beds for many of our patients. But now the situation seems to have eased a bit, in a sense that lesser number of cases are coming up, especially in the last few days. Probably the result was, as a direct result, it was because of the effect of the lockdown, or the number of testing of these patients have come down in the last few weeks. Initially, In the last week, we used to do, on an average, we used to do around 1,90,000 tests per day were being done in Karnataka. Now it has come down to hardly 95 to 1 lakh per day. Overall, the situation is much better. Even in Bangalore also, through some of my friends and my relatives, I found out that it is now possible to get a few oxygen beds, and if you're lucky enough to find a ventilator bed too, treatment is now, is available, is being made available. Hopefully, because of the lesser caseload, I think if the situation continues in the same way, things might be easier for the general public a lot more.
Great. Thank you so much, Dr. Chandrasekhar. And one of the questions which is coming, Dr. Lalita, to you is it good to get vaccinated in pregnancy? If so, when to get it?
Thanks, Bridge, for bringing up that question. Yes, the data is showing that pregnant women and lactating women can take the vaccine. And I do have a video, actually presentation from one of my friends in Karnataka, which I will want to share it in the WhatsApp group, where she has given the message in Kannada. I'm not sure which language your patient is speaking, but she has clarified all the queries that come with pregnancy and lactation and vaccines and coronavirus infection in general. So it is safe. I mean, there is data. And when, after any time after they know that they are pregnant, with the consultation of their obstetrician, they can take the vaccine.
Great. Thank you so very much, Dr. Lalita. And
I would like to make it.
I
would like to make a point here. As per my knowledge, as per the current government advisories that are available, still pregnancy and lactation are not being considered for routine vaccination. Yes, under exceptional circumstances, probably they might be permitted. But as per present guidelines from the government in India, as of now, pregnancy and lactation, pregnant ladies and lactating mothers are not allowed for routine vaccination. Kindly check up with your gynecologist and make sure that you are eligible for it.
Thanks, Dr. Salimat. And that's why that Indian voice is so important, because we also get a lot of information and we don't know which one is accurate information. So thank you so much. Appreciate it.
So Dr. Lalita, here too, we have a couple of folks who were pregnant and did not take the vaccine. Just so you know, unless maybe the guidelines have been updated. That's another thing. That's why, specialties talking to each other like this is important. But guidelines are being updated. So maybe, Dr. Lalita has more later information. They had not, because it has not been tested in pregnant women, and with their lower immune, status, we need to be a little bit careful.
I agree with you, Dr. Shobha. I agree with you. I misheard the question. Sorry.
Okay. I wasn't sure, whether, because there are updates, and internal medicine, critical care gets the update much earlier than we do. And we always want to ask you, in that situation. So no worries. I mean, it's a changing field. And like you say, we are getting so much information. We don't know if we should listen to the OG Society, you should listen to CDC guidelines or, WHO. So it's all good. That's why it's good to, we get a lot of things for our cats and heart failure. So no worries. No, thank you for clarifying, Lalita.
No, I apologize for that, Bridge, because I was just focused on the cardiology part and suddenly you took me into the obstetrics part. And so my sincere apologies.
My apologies. My apologies for that, and that's a good discussion, and I appreciate that we come to a very clear message to all of us who are listening and who would be listening to this YouTube video later, that please consult your gynecologist. Also, time to time, these updates would be coming from companies who are producing the vaccine, whether it's Covishield or Covaxin or Sputnik or Pfizer vaccine, and maybe then 5th and 6th or 7th vaccine coming in India. We need to double check before taking it for pregnant women. That is the message loud and clear for from all of you. Thank you so much, Dr. Shobha, Dr. Lalita, and of course, Dr. Chandrasekhar. So we take up the last question from the chat box, which is coming up, that this is being asked by Harish Kengeri. Airborne virus not confirmed by medical fraternity as of today. Is it only social media spreading it, or is there any truth behind this?
What was the question again, Bridgie? Please.
The airborne, the virus spread, is it truth or is it only social media?
Oh heavens, yeah, if you want to remain on social media inside your house, then that's true. I mean, I know I'm the cardiologist, I'm jumping in before all the pulmonary and ID, but it's truly, respiratory inoculum. You have to be around for about 15 minutes. That's the exposure time that's being given. But, when the density is very high, it's purely by airborne medium. So anyone else, you have more insight into that, but please don't believe such things. That is why these social media fake news spreads. This is the difference between life and death. Please do not, our mask mandate is based on that. And so please don't listen to conspiracy theories. I had to jump in because this is like the bottom line. And we don't want anybody leaving here with a gray zone, like, oh, is this airborne or not? It is airborne. That is the only, like respiratory inoculum. That's why it spreads from people to people. But there are much better respiratory experts here who can give you more insight into that. But don't ignore that. That's why I jumped in. Sorry.
So, Dr. Bijmohan, Dr. Aaron, if I can jump in.
Yeah, please.
Couple of things. They have to. We know that it is spread by droplet infections, and the exposure has to be, as Dr. Shobha mentioned, about 15 minutes. I think Dr. Sharma can confirm that too. So far, I don't know about any clinical trials that says that it is just airborne. If you just step out of the house or open the door, you will get the infection. I don't think, that kind of severity of spread has yet been confirmed. I don't know if they're doing trials in India, but I just want to say some daily routine good habits. Everybody, if they can do an exercise every day, you mentioned yoga, abdominal and respiratory. Good food habits, high protein diet, low carbohydrate if possible, and low salt if possible, and taking vitamin C, taking vitamin D, zinc, antioxidants every day. Good food, avoiding high carbohydrate, and taking your medications, controlling your blood pressure, controlling your sugar. Initially, there was a scare that ACE inhibitors, people who were taking the COVID virus attaches to the ACE receptors, and therefore people were worried about ACE inhibitors to say those on ACE inhibitors may have a higher affinity to get COVID. Later on, the clinical trials suggested the risks outweigh the benefits. So, the benefits outweigh the risks. So please continue to control your blood pressure, control your diabetes, take these additional precautions, and daily exercise, daily healthy life, good food, high protein, and above all, be mentally strong. As long as you have good mental approach, attitude, your hormones will generate good immune systems, and it is the fight of the immunity against the virus. So have a very strong, clear mental health, and to stimulate the right hormones and stimulate your immune systems to fight the disease.
Thank you so much. Thank you so very much. There's so clear message that spirit, the might is bigger than anything. And I have experienced it two times impact from the COVID. And I don't want to get the third time for sure. But, just sharing here, once you have decided that you come out of it, you'll come out of it. Of course, with very good suggestions and advice you have given. Thank you so very much. And I would like to take up, so many questions are coming still, but for sure now it's almost we have been going, I think, more than 110 minutes, I believe. So we'll be trying to wrap up now the session for today. We'll be continuing this series for sure, and I'll be requesting now my colleague in Rotary, Bangalore, District 3190, Rotarian Ramesh, to have the formal word of thanks to all the doctors, team from US, India, and all the attendees here. Over to you, Rotarian Ramesh.
Yeah, good evening, everyone. I am Ramesh Shivanna, President for the Rotary Green Park, and also represent Chronic Foundation. It was a wonderful panel today, the eminent doctors sharing the different experience from the different part of the world with their best practices for the coronavirus infected patients. It gave deep insights into the topic and also revealed some interesting facts. The knowledge sharing for the COVID pandemic is very much necessary. The sudden outbreak has created a lot of panic to all of us and also even to the doctor community. Our cautious hope must be balanced and with the speedy and rigorous clinical trials to be provided evidence of effectiveness. Vaccines are now available to protect against the coronavirus. Researchers are also working on creating more potential treatments for COVID-19. So I thank each one doctors and panelists who have taken time to be a part of this panel in spite of the busy schedule and engagements in your professionalism. And more than that, all are in the different time zones. Dr. Lalita from Illinois, Dr. Shobha from again same place, and Dr. Subhashri, Dr. Rakesh Sharma from New York, Dr. Kushbu from Atlanta, Dr. Samar Mehta from Houston, Dr. Mata S. Arun from Florida, Dr. Chandrasekhar Salimat from again Florida, Dr. Krishna Prasad from Bangalore. Thank you all once again. I also thank Rotarian Bridge Mohan, Rotary Lanka, for moderating the wonderful session and coordination of all the doctors. I also thank all the Rotarians from Green Park Club, Yelahanka Club, Rotaract team, and the Chronic Foundation team, and also people who participated in this session. So, and I am sure we are continuing this education series shortly. We'll catch up once again. Thank you very much.
Thank you. Wonderful Sunday, all of you. Dodda Namaskara. Thank you. Dhanyavadagalu.
Thank you.
Thank you. Bye. Namaste. See you.